Hello, I'm your host Kazim Bibijan. I'm a specialty registrar in public health in the UK, and I'm really excited to welcome you all to a special series of episodes in partnership with the Faculty of Public Health. The aim of these episodes is to showcase the candidates running for the 2024 Faculty of Public Health elections. We'll be joined by the candidates for President and Vice President, and we will be exploring their vision for the faculty and why members should consider voting for them. Voting opens on Thursday, the 14th of November, and closes on Thursday, the 12th of December. In the second episode of the series, we have the absolute pleasure of hosting Dr. David Walker. David has over 3 decades experience working across the public health system, both nationally and internationally. David originally trained in medicine and infectious diseases before training in public health. David has developed his senior leadership skills across a wide range of roles in his career, including as a CCDC in Durham, as a Director of Public Health in Newcastle and North Tyneside, Regional Director of Public Health for the North East, and as the Deputy Chief Medical Officer for England between 2013 and 2015. He has also held a number of senior roles, including Chair of the UK National Screening Committee and National Lead for Rare Diseases, as well as a number of academic professorial appointments across a number of universities. Currently, David is the Chief Medical Officer at the Mid and South Essex NHS Foundation, one of the largest acute trusts in the country. David, welcome to the podcast. It's a pleasure to welcome you.
Thank you very much, Kazim. Just to correct one thing, I've recently retired from Mid and South Essex Trust, so
Okay.
I'm currently unemployed and willing to throw myself into the presidential role full time.
That's good for listeners to know. Great. So we'll start off with the first question, really, of the election. Why did you put yourself forward to be president of the Faculty of Public Health, and what were the kind of motivations around that?
Okay, I think the first thing to say is that I think the faculty is an incredibly important organisation, and particularly now needed more than ever. I think it's achieved a lot. It's a credit to its profession, and I think it's a force for good with incredible potential to influence the health of the population of the country, and I would be really proud to represent it as an officer. But I am really concerned about the future of the public health specialty. So if I could just take you back 3 decades to when I first got involved in public health, it was a fantastically exciting place to be. You know, we had well-resourced local teams. We had public health experts on the boards of all of the organisations which managed health spending in the UK. So not just the 3% related to public health. At that time, we had influence over the entire health budget. And we had strong regional leadership with regional directors of public health linked to the CMO and to wider government. So there was tremendous scope for innovation, for research, and for service development locally. So there was a real optimism, a feeling that you could do great things. And the system, which was the NHS at that time, with strong public health representation, held responsible organisations to account for delivery of public health objectives. And that was a really strong place to be. And for those who weren't around at that time, public health was the most popular specialty for medics to apply to go into. And public health careers were associated with very high rewards and great opportunities locally, nationally, and internationally. And in the first 10 years in public health, we saw some really important developments. The establishment of Public Health England, and the adoption of multidisciplinary public health by the faculty. And at that time, public health outcomes were at an all-time high and improving month on month, year on year. So I wonder if I'm looking back with rose-tinted spectacles, if I'm honest, but actually it felt like a really wonderful period for public health. And then over the last 15 years, things have not been so good. Public health moved into local authorities, which I think was a good thing, but that coincided with reduction in local authority budgets, which has been sustained over a long period now. Budgets have been cut, remuneration of staff has not kept pace with inflation or with comparable careers. Local authorities have sometimes moved the Director of Public Health away from being at the top table to second-tier leadership roles where it's harder to influence the functioning of the entire organisation. And then, of course, we've seen the abolition of Public Health England during the pandemic, which didn't send a great message, and without a clear plan for the future of the functions that PHE had. The successor body, UKHSA, has got a much narrower focus, and so it's harder for that organisation to either coordinate public health activity or to advocate comprehensively for the entire public health family. And also the regional teams no longer have a direct managerial link to local teams or to the wider government structures, which was so helpful before. And OHID, I'm concerned, is now being effectively dismantled. Governments do this. If they want to get rid of something, they move it into a different department, strip out the leadership, and then the functions find it very hard to be sustained. So I think that we've got now a fragmented system with no clear structure for coordination or for promoting system change. And disturbingly, at the same time, public health outcomes have stopped improving, and in some cases, they're worsening. So in short, public health has lost its coherence. It's lost its unified voice. And whilst the faculty has done a great job in setting out the policy agenda, there are many public health specialists, and I would single out some directors of public health particularly, who have performed heroically to keep the wheels on. But the specialty seems to me to be in a state of progressive decline. And there's no obvious vehicle for recovery at the moment. And when I talk to directors of public health, they are generally frustrated and morale is falling. They feel they're swimming against the tide in a system which is not working for them, where they spend much of their time defending their budgets when they would rather be leading public health activity. So I'm concerned that if we carry on in the same vein, a few more years of this is going to leave us in a very difficult position, where we fail not only to deliver on our policy objectives, but the thing that worries me more than that is that we will fail to attract into the specialty the leaders and the stars of the future. As a faculty, we should be looking not just to set minimum standards for public health, but also to encourage greatness in our youngest and brightest recruits. So putting all of that together, it's a long-winded way of saying that my reason for standing is that I believe we need a change in direction to support our local authority public health teams and provide the common voice for our concerns so that we advocate not just for public health policy, but also for an effective public health system.
Yeah, thanks, David. Yeah, so really useful for your reflection, I guess, on your experience in public health. And yeah, as you said, making the public health specialty attractive to that talent and retaining that talent. So I guess on that note of how you see public health over the last 30 years, what is your vision for the faculty if you were to be appointed president over your 3-year tenure? And what are the sorts of things that you will be prioritizing?
Well, I don't want to talk about public health policy per se, because we don't have enough time for that, I think, here. And anyway, I think that over the last few decades, public health specialists and the specialty generally have done a really good job of analysing public health research and routine data so that we have a pretty consistent view of what the priority issues should be for improving and protecting the health of the population. And of course, that will evolve over time and change with events. But I'm sure if at the moment you took 10 public health teams from around the country and asked them to write a national public health strategy, they'd all look pretty similar. And I expect by the time our next 5-year strategy comes up for review, we'll have AI to do that for us anyway. So I think that the big issue for me is not actually that policy area, important though it is. It's about how we support the local public health workforce with an effective public health system. So what that might look like then, I'll just give you 2 or 3 things. The first thing is I think we need a national conversation about the future of the specialty. And this brings a spectre of reorganisation. Personally, I don't want another reorganisation. I've been through a lot. And they always seem to sap energy and use up resources and often don't yield a lot of benefit, if we're honest. Although I am willing to be challenged on that. But I would like to hear from the ground up how we could change things for the better to make what we've got work better. I have my own ideas, but 1,000 heads are better than one. And I know from experience that the people on the front line usually know the best solutions. So I think collectively we need to do some work on making the most of what we have. And the sort of things I want to know are, how do we join up what is now a very fragmented system? How do we increase the influence of public health thinking and science in health decision making? And I mean health decision making in its broadest sense, from government down to local level. And particularly, how do we attract the very best people into the specialty and provide them with the exciting, rewarding, and modern careers that they want? And following that, we need a plan for making that change happen. So that's the first area that I'd really like to prioritize. The second area is managing upwards. At the moment, there's a fantastic opportunity. We've got a new government that's come in. It's minded to invest in health, and it's working its way through how to do that. But the national conversation at the moment is not about public health. I was listening to Wes Streeting in his speech yesterday, and it was all acute care focused. It's about activity, waiting times, acute trust managers. And I see huge sums of money now being thrown at secondary care teams to bring down waiting lists. We're paying consultants more than £200 an hour to do this work. Little focus on prevention. I think we got about 20 seconds in that speech for public health, a little bit on primary care. So we need to influence and change that narrative in a much more proactive way. So that's the second area that I'd like to prioritize. And the third area is around our approach to, and I say this, choosing my words carefully, multidisciplinary health, public health. And I'd welcome a conversation about how we improve that. And before I set any hairs running about suggesting we return, I'm suggesting we haven't gone far enough. I remember I was at the faculty meeting where we agreed wholeheartedly to open up the faculty to non-medical public health experts. And I don't think there are many people who think that was a bad idea. I think it was a good start, but it was not nearly ambitious enough, and we haven't followed up on it. So if you look at training programs around the world, I worked in the United States and worked with the EIS program, the Epidemic Intelligence Service program, which you might be aware of. Now, they take applications from public health doctors and nurses and allied health professionals, of course, but they also recruit veterinarians, finance experts, lawyers, engineers, and in particular, experts in digital technology and communications. So their objective is slightly different from ours. We are looking to take individuals at an entry point and ensure that they reach the standards required to deliver public health in the UK. So we're looking to produce a homogenous product, a monoculture, if you like. Their intention is completely different. They want to start with experts from a wide variety of fields who are already expert and able to contribute, who also have a passion for public health, and then equip them to work in public health teams. So that gives a much richer diversity of people with specialist skills who are also committed and trained in public health. And I think we don't really have a place in our system at the moment for those individuals. And I would like to see that, because increasingly we're going to see the impact of particularly digital, social media, and AI in the future of public health. So we need to find a way of working much more closely with those groups. And I haven't got a vision for how we do that, but I would like to have a conversation with those constituencies about how best to do that. And I also think we need to be looking more at learning from other public health systems. 20 years ago, I think our system was envied by many in the world. It was greatly respected, and I think it still is to a degree. But other systems have moved faster and further. And I think that we need to work with those systems to understand what we can learn from them, and of course what they can learn from us. And some of that is already happening. And I know that there's lots of individuals involved in that kind of work, but I just think we need to move that agenda faster. So I think those are the three areas I'd like to focus on.
I mean, certainly on that last point about learning from other public health systems, that was a key lesson learned from the COVID pandemic as well, really. But fascinating points, David, especially about empowering local public health, that improved focus on prevention and managing upwards, and promoting more multidisciplinary working and thinking in the public health workforce. So really fascinating. And on that point about the public health workforce, so the third question that we would like to ask you as a candidate is, how will you contribute to ensuring that FPH members are supported across their career paths in order to meet current and future public health challenges?
Well, I think one of the things that people need when they're making a career choice is certainty about what the future looks like. And so I think we need a comprehensible public health system which provides an environment in which talented public health specialists in which they can navigate, first of all, but also then succeed and make a difference. I think at the moment, many directors of public health succeed because basically they're fabulous people. They use their personal power, integrity, credibility, the force of their character to achieve change in very difficult circumstances. And in the absence of the positional power that we used to have, that kind of heroic leadership is necessary, but it's not sustainable in the long term. So we do need to revisit the position of public health in the health and care system. And that's part of the national conversation that I mentioned earlier. But I think public health will decline further unless we can offer exciting opportunities for those wanting to enter the specialty. And as you mentioned in your introduction, I was lucky enough in my training to work in a wide variety of academic and service programs in the UK and abroad. And whilst there are some of those opportunities available now, I think it's much harder. And so, again, I would like to see how we could look at training programs around the country and create a greater diversity of training opportunities, particularly in light of the technology and information changes which are coming rapidly down the track. And I think greater diversity in the public health workforce will equip us for that future. And I don't mean diversity in terms of gender or ethnicity. I actually think we're pretty good at that. I think it's diversity of experience and skills and perspective, which will be essential in the period of rapid change that's to come.
Yeah, to your point, is that providing that environment for talent to improve, and that that heroic leadership not being sustainable at a local public health level. And our last question for the episode. It's a theme that we do like to visit on the podcast. So there's kind of softer skills. Registrars, are in leadership positions not only in training, but then go on to consultant positions where they may be leading teams and providing that leadership in the system. But I guess in your experience, what do you think makes a good public health leader, and how would you describe your own personal leadership brand?
Public health leadership is really hard and is often underestimated, especially in austere times when it's most important. There is an argument about whether great leaders are born or made, but I think that everybody can improve their leadership skills and capacity and capability. And I think the faculty and indeed other national local organisations have done a lot to promote that over the years. My personal view is that leadership development, mentoring, coaching, and particularly reflective activity are essential, not nice to haves, and should be part of our routine practice as we develop as public health specialists, so that right from the beginning of training, right until you leave the specialty. So my approach to leadership in public health is facilitative and through consensus. I know that conversations about vision and values can be a turn-off for some people, but I think they're really important. And I think leadership is about coalescing around a common vision, which is born out of our shared values, and then the relentless pursuit of the delivery of that vision with real determination. That's what makes a good leader. And I think leaders should be constantly assessing their progress against delivery of that vision and reflecting on how they're moving towards it, and also demonstrating their values in all that they do. And it means your whole life, not just when you clock on to work. And I recognise that the engine room for public health and for most of the creativity that we need is actually at local level. But the purpose of the faculty and its leaders is to promote and facilitate the development of the environment for local teams to thrive and succeed, including through education, advocacy, negotiation, and a whole range of other activities. And I think the last thing I'd say about leadership is that we need to make the world exciting for people within and coming into the specialty. Public health work is really important and it's really serious, but it should also be interesting and enjoyable as well. So we need to do great work, but we also need to create an environment which is a great place to deliver that work in.
Really interesting points, David, about that making public health exciting and making it an environment where people can thrive, particularly at a local level, and that your leadership values of demonstrating those values in every aspect of professional and personal life, and that relentless pursuit of delivery of a vision, which I thought was really interesting. But that was our last question, and hopefully gives listeners a good taste of your background, your experience, and your kind of vision as a candidate for potential president of the faculty. And thanks so much for making the time, David. It was a pleasure to host you.
Thank you very much, Kazim.